everybody. Great to have you here. Today's webinar is in English, but we do have simultaneous translation. I know there's a lot of people that are interested in this webinar. And we have a very special guest, Mark Grabowsky. Mark, welcome. Great to have you. You are, let me congratulate you, because you are our first repeat guest on this webinar series from Philandropia, Puerto Rico. And we are so honored and happy to have you back and to have you on this, talking about COVID. You were here with us on March 24th, just a couple of weeks ago, and we started lockdown on March 15th. From COVID, and at that moment you gave a perspective on how the pandemic was going on, how was the successes and failures in different places, and how we could, as a community, we could respond to this pandemic. And as we go into this new phase, in June, and everything is kind of opening up, and people are tired of being in lockdown, and there's data coming from different parts. We invited you, and you accepted the invitation to come back and talk a little bit about the future of this pandemic and where we are, what things we should look at, and we're very, very excited for this conversation. So for everybody, before we get started, again, choose your channel at the bottom of the screen. English, you'll be listening to us in English. If you want to listen to this in Spanish, pick Spanish. Send us your questions that we'll be addressing at the end of Mark's presentation in the small icon that says Q&A at the bottom of your screen. We are recording and transmitting on Facebook, so we can get questions from any of these places. And I want to read the bio before we start. Mark, because we're very lucky to have you be a resident of Puerto Rico, this great resource. So for anybody who didn't participate on Mark's first webinar, we have that recording, and we'll share that link with you so you can kind of see that if you're interested. But Dr. Mark Grabowsky is an internationally recognized expert on disease prevention and child health. Across his career, Dr. Grabowsky has also held senior level posts at the World Health Organization, Center for Disease Control, National Institute of Health, American Red Cross, and the Canadian International Development Agency. He has over 25 years of experience at the forefront of significant global health challenges, including efforts to reduce measles and malaria deaths in developing countries and advance HIV prevention strategies. At NIH, he was Chief of HIV Prevention Research and HIV Vaccine Clinical Development. At CDC, he founded and led global partnerships for measles and malaria control, and has worked on disease control efforts in over 30 years. With the UN Special Envoy's Office, he was responsible for directing strategic partnerships to finance the United Nations Millennium Development Goals. As Deputy Director of the National Vaccine Program Office, he was on the National H1N1 Task Force and led efforts to increase flu vaccination nationally. His most recent position was as Chief Medical Officer at Pentrix, and he currently resides in San Juan, Puerto Rico. Again, we're so honored and great to have a resource like you here, and that you accepted an invitation for a follow-up webinar. Thank you, Mark. And how are you before we get started?
I'm doing fine. It's a pleasure to be back. Thank you very much, and looking forward to it.
Awesome. So I'll leave it to you. Again, folks, leave your questions. We'll address them at the end, but I don't want you to forget them. So leave them on the Q&A box. Mark, take us away.
All right. So Glynis, thank you to you and the team at Philandropia for making this possible, and thank you to the audience for giving us the time to explain these things. I'd like to start off by saying that I found this to be a very difficult presentation to put together for a couple of reasons. One was because the data are so raw and so confusing and changing constantly. And many of the publications are not peer reviewed, which is important for scientists. Some are being withdrawn. There's a large political element to both the data and the science. And so it's very difficult to understand, draw perspective from it and understand a true meaning. The second thing is that as an epidemiologist, often I talk about historical diseases to audiences that are removed from the disease, policymakers not really affected by the disease. And this is a disease which I'm affected by and all of you are affected by, and it's happening in real time. And so there's a certain element of responsibility to really try to get it right, understanding that I and others are going to act on the information, and we're constantly making decisions every day about how to behave and what risks to take. So I found it difficult, and I hope you'll bear with me, and we can go on this journey together.
We appreciate those comments, and that's exactly why we wanted to have you back. There's so much information. We're affected by it. This is changing us in all ways, and we value very much your opinions. So thank you so much. Take it away.
Okay, so let me put on screen share here. Okay. All right. Okay. So I'd like to give an overview of sort of where we are, what the data says, give you a perspective as a background for then where we may be going and sort of what the science and learnings so far tell us. One of the first things I'd like to point out is that many of epidemiologists, including me, were wrong from the beginning about this disease. And I want to explain why we were wrong to give you a sense of how we think about this. There were 6 previous coronaviruses that affected humans. This chart shows the course of the coronavirus SARS-1. We're now in SARS-2, but this was SARS-1. And this outbreak curve, or the epidemiologic curve we call it, is from 2002 to 2003. And there have been no cases of SARS-1 since about 2004. So many of us, epidemiologists, took our lesson from the most recent coronavirus. So we had recency bias, and we thought it would come and it would cause a few cases and it would go away. We neglected the 5 other previous coronaviruses, 4 of which cause the common cold and are endemic around the world, and we get repeatedly infected by it. And they are pandemic viruses, but mild pandemic viruses. And the 5th one, which is endemic to the Middle East and has a camel vector. And so humans and camels pass the disease, and it's endemic to areas that have camels, but it has not gone away. And so we suffered from this bias of our most recent experience. Many of us worked on SARS-1 also, and that was what we expected to happen, but it didn't. And so it revealed our lack of perspective in looking at the whole range of disease. So the issue of bias has become important in this. And one more issue about bias, I'd like to state my personal bias. And my personal bias, and there's a lot of things one could value. One could value economics or institutions or children or reducing cases. My particular bias is protecting those who are least able to protect themselves. In this case, it's the elderly, the sick, and the institutionalized. And certainly there are a number of reasons one could have other values or bias to apply, but I'll lay it out front. That's particularly is mine, and it will become a focus of this talk. The first thing I'd like to say is that we need to become very aware of the quality of the data. And to exemplify this, these are data from Los Angeles and New York that show case reports. So you see the case reports all the time in the newspaper, and these are case reports from Los Angeles and New York, where they just took a number of cases and divided by the total population to get the percentage of the population that was reflected in the case reports. And in Los Angeles, less than 1% appeared in the case reports. And in New York, about 1.5%. But the next thing they did was they did random serological studies in the population to check for antibodies to see who was ever infected with COVID-19. So who would have been an infection? And these are what those data are. And what we see is there are substantially more infections than there are reported cases. And in fact, in Los Angeles, for every case that was reported, there were 16 hidden infections. And in New York, there were 10 times as many infections as there were cases. And so as we see data, and we say, oh, there was 100 cases, well, really 100 times 10 is 1,000. And so that should be 1,000 cases. So as we try to calculate what is our risk, we need to really understand what's happening out there. And these are data from Puerto Rico, looking at the blue line at the bottom is what we see in the newspaper, the daily reported cases from the government. And the orange line is what would happen if those were underreported by 10 times. And you can see that instead of having 150 cases a day, we're seeing 1,500 cases a day. And so this kind of issue about the quality of the data pervades the data for this disease. And it becomes difficult to really truly understand other than we can look at trends in the disease. So these are the death data, and the death is being underreported as well. And if you look at, this is data from Centers for Disease Control, and everybody who dies from whatever cause in the United States gets a death certificate, and the doctor fills it out and says what the cause of death was, and they say a confirmed cause or a probable cause of death. And you'll see the dark blue bars give the confirmed causes of death that was on the death certificate. And for some people, they couldn't meet the definition of death. They didn't have an antibody or the PCR assay available, for example. They weren't examined in time by the physician, or they died at home. And so we fill it out as probable, and that's the light blue bars. And the dark line, the black line, is actually, there's this curious phenomena where during the time of COVID, there are excess deaths for which no one quite knows how to account for these excess deaths. And so one reasonably might attribute them to coronavirus and the time of coronavirus, but not quite sure how to count them. So what we think is happening is that deaths are being underreported by about 30 to 50%. It's better than the case data. And so if one really wants to know what's going on, it may be better to look at trends in death data. But again, both data sources are flawed. And so we tend to look at trends in the data rather than the actual absolute numbers. So let's look at some trends. So this is the trends in the global data. There's about 100,000 cases occurring daily globally, and it's accelerating. The panel at the bottom shows the 7 largest countries by population. China is on the blue line at the bottom. It's going down. It's controlling the epidemic well. The United States on the top, we'll say more about that later, but it's flat. And the other 5 countries, Brazil, India, Pakistan, Indonesia, Nigeria, which are huge population countries, developing countries, are all increasing exponentially in their numbers of cases. So the pandemic is accelerating globally. So let's look at the US. The US is having about 20,000 new cases every day. But let's look at the top 10 largest states in the US. 4 of those states are increasing. And these little charts are individual data taken from the New York Times. 2 of those states, Georgia and Ohio, are about the same. And 4 are decreasing. And New York sort of dominates the scene because there's such a large outbreak in New York. And in fact, if you subtract the New York decline from the US data in general, it turns out that outside of New York, the United States is increasing everywhere, is increasing as a country. So the decline or artificial decline we see in the US data is really an artifact of the New York success in controlling the outbreak, and the fact that New York sort of went first and has gone through the cycle of the outbreak. So it's important to sort of disaggregate the data to really understand what's happening on a national level. Here's the death data, and deaths are trending down in the US. We're about 1,000 a day, and this is probably a little more reliable than the case data. And let's look at the top 10 states. About 8 are staying the same. of the top 10 states. And these are death data by state. And 2 are trending down. And it's the same phenomena where New York, which is in the bottom left-hand corner there, had huge numbers of deaths, and those deaths are now falling rapidly. In fact, New York last week had its first day with 0 deaths during the pandemic. And if you sort of subtract the New York experience from the overall national experience, deaths in the US are actually increasing. So let's look at what we've learned so far about risk factors for the disease. And by far, the dominant factor of this disease is the importance of age. And these are data from California, which show age groups. And this is the population in California. It has nothing to do with disease, it's just the distribution of the population. And you'll see that sort of skews left, and California is a young state with lots of 0 to 17-year-olds and 18 to 34-year-olds. Now, if we add in the case data, so the red bars represents the COVID-19 cases. And if you look on the left-hand side, you'll see that there are fewer cases in younger children. So that's an important feature. But otherwise, the percentage of cases sort of follows the population data, including on the right-hand side for the elderly. The elderly are at no greater risk of getting the disease than you might expect from their percentage in the population. But if you add in the death data, and this is the percentage of the age distribution of deaths, the percentage of deaths by each age group, what you can see is that it's dominated by the older folks. And so in California, where the elderly make up maybe 15%, those over 65 make up maybe 15% of the population, they make up 60 to 70% of the deaths. And this scenario of the elderly being at no greater risk of disease, but a much higher risk of death, is sort of the dominant factor, in my opinion, of this pandemic. So these are the same data for Puerto Rico. The blue bars are just the distribution of the population. The red bars are the COVID-19 cases, which sort of follow the population distribution, except for the younger folks who seem to have less disease. But the dramatic increase in death among the elderly, again, the elderly make up of those over 70, in this case in Puerto Rico, make up, say, less than 10% of the population, but are something like 60 to 70% of the deaths. So again, mortality associated by age is enormously important. The other factor that's a risk factor that's becoming apparent is race as a risk factor. And race is, of course, tied up with poverty and disease and lack of health services. So it's a marker for a number of other things. But if we look at, these are the data in the top 10 largest population states. And the way they're presented is that each bar represents that race's relative risk of death compared to the white population in the same area. So if you look on the left in California, where the blue bar is around, say, 2, that means that blacks, represented by the blue bar, have twice the risk of whites. And you'll see Hispanics in orange is about same with whites. So what we see across these 10 largest states is that in every state, blacks have a higher risk of death. And on the far right, Michigan, it's 4 to 5 times higher than the white population. But it's a mixed story for Hispanics. In some places it's higher, such as New York or Illinois. In some places it's lower. So it's unclear what's happening in those populations. It may be that the cofactors of which race is a marker for in New York and Illinois, which may be poverty and lack of access and poor housing, et cetera, that those factors may be more prevalent in those cities. But certainly Black race along with age are 2 important factors. One of the issues that's also dominates the outbreak is the political influence on data and policies. And I think all of us are aware of the issue of the president wearing a mask and reluctance to model behaviors recommended by his administration. I think many of us are aware of the chloroquine, which I would call a debacle, where chloroquine was being essentially pushed by the White House without data. The data became politicized. There was a rush to get data. 2 recent journal articles were retracted because of the poor quality of the data. And so it's a very difficult situation and unusual in my experience of disease control, where normally these issues about which drug to use are strictly driven by the data and cost-benefit analysis, and there's almost zero political influence in terms of drugs. So that's a new experience. But I'd like to focus on one particular thing to illustrate this, which as an epidemiologist, I think is illustrates for me this issue of how we think about political effects on data and policies in this pandemic. So this is a report from the Centers for Disease Control done last month, in which they looked at cases that were occurring among members of a choir in Washington state. And it turns out that a large number of the members of the choir got the disease. And so they did an investigation, and here was their finding, was that 87% of the choir got the disease from one choir member who came. And their conclusion was that singing in a choir, because of the singing and forceful expulsion of air and being in a closed place, that might be a peculiar risk factor for the disease. And so in their article, they came up with this conclusion that the attack rate was high and it might be transmissible in certain settings, including group singing events. And this is pretty standard CDC case investigation language and sort of drawing a recommendation directly from the data. And so then they took this scientific report and they translated it into public policy. And this was the public policy they wrote. Consider suspending or at least decreasing use of a choir musical ensembles, if appropriate within the faith tradition. Then they cited the actual data that supported that previous line. The act of singing may contribute to transmission of COVID-19, possibly through emission of aerosols, in a very fine scientific statement. What we saw, though, was that the next day, the administration changed this, as reported in the Washington Post with that headline, that they changed the language and removed the stronger recommendation of suspending or decreasing to promote social distancing as circumstances allow, and remove the actual data that singing causes transmission. And while it may seem minor that it's a choir issue, it speaks to the larger issue of, are there other policies that the administration or others have changed before they were made public? And are there certain things that are not even being investigated? So, for example, if there have been other outbreaks in choirs, has the administration said don't investigate them? Have there been outbreaks at voting places? Because the administration wants to keep open voting, so maybe those aren't being investigated. Have there been outbreaks at political rallies? We're not sure of that. And so as a former CDC epidemiologist, sort of breaks my heart to understand the politicization of the policy process. And the question becomes, do we have to take what was formerly the most trusted institution among epidemiologists and start to question where those recommendations are coming from? So that seems to be a unique feature of this pandemic. So one of the questions we all ask is because of the main tool is social distancing, and we're all practicing social distancing to some degree, how effective is social distancing? Well, data are starting to come out on that. This is a map of counties of the United States, and the circle shows the border between 2 states. The state on the left, which is here, is Iowa, and the state on the right is Illinois. Chicago's up here on the lake. And this is the Mississippi River that runs between them. Well, Iowa was a conservative state with a Republican governor that said, we're not going to do social distancing. And so they did not have a strong recommendation of social distancing. Illinois was a red state with a Democratic governor and a large city, Chicago, that strongly endorsed social distancing. And the populations could not mix across the river. but they were demographically similar. So it became a good natural experiment to see what would be the difference in disease transmission from these counties across Mississippi River. So here are those data. And what they saw was that in Illinois, which had stronger social distancing, it had a 30.4% reduction in excess COVID-19 cases, and there was a P of 0.02, which means a highly statistically significant finding. So it's sort of a benchmark that maybe the social distancing reduces cases on a population level by about 30%. Now the individual level is different because if I'm an individual and I practice strict social distancing, I may be more protected than 30%. But on a population level, what's happening out there for everybody else besides us individuals, that's a 30% reduction. There was another natural experiment across two countries, the countries of Norway and the countries of Sweden. So Norway was a country that adopted sort of what we're calling sort of standard social distancing, which is intensive, stay at home, wear a mask, don't go out unless you have to. Bars were closed, restaurants were closed. Sweden had a different theory. Sweden's theory was, let's get everybody infected and get herd immunity because everybody's gonna get infected anyway, they said. So let's get it over with. And so they had very little social distancing in Sweden. And so they were able to go back and look at mortality by population rates in Norway and Sweden. But first, let me show you something that's a very interesting source of data called the Google mobility data. And this is actually a measure of social distancing. I'm not sure you've ever seen this, but if you do a Google search on Google mobility, it comes up and you can plug in any geographic area, country, or region of countries or states in the US. And it'll give you the graph that looks like this. We have one here for Norway and one for Sweden. And what it shows is the reduction in attendance at various places. It uses the GPS feature of our phone. And you may know that if you go into a shop, sometimes you'll get an ad relevant to that shop later. That's because Google knows that you went into that shop from the GPS feature of your shop. It also can use that to measure how many people stayed away from restaurants or shops or gyms or other things. And they put that in their Google mobility data. And so Norway on the left had pretty good distancing, was 80% decreased at times from the baseline. And the baseline was the average of the month before the outbreak started. And average sort of around 40, 50%. Sweden had some social distancing. It sort of never really went below 40%, averaged around 20%, sort of like half the level of social distancing in Sweden as we saw in Norway. And so these are the data. And what we can see is that Sweden had 27% more excess deaths than Norway did, which had no increase in excess deaths. And so in the Iowa, Illinois data, we had about a 30% reduction. In the Sweden-Norway data, about a 27% reduction. Now, this is a publication that came out actually this morning from Nature, which did mathematical modeling of looking at all of the combined efforts and their effect on reducing transmission in various populations. And so they looked at 5 countries, China, South Korea, Italy, Iran, 6 countries, and France, United States. And the blue dot shows the effect. And so in the US, it was basically around a 31% reduction from all factors combined, not just social distancing, but a whole range of other factors. If we looked at the US alone and looked at social distancing alone, there's about a 21, 22% reduction attributable to social distancing alone. So what we're seeing is that on a population level, social distancing is in fact the most effective tool we have and has a measurable effect on reduction of transmission. So the initial data suggests that intensive social distancing may reduce societal cases and deaths by about 25 to 30%. Again, not the same as individual risk reduction, because as an individual, we can actually reduce our risk to 100% just by staying inside and away from everybody, but it measures what the society as a whole has done. So now that we've been doing social distancing, the question is, how do we get out of this and how do we sort of open up? And these are the White House criteria for how to open up. And it's the these are the benchmarks which need to be satisfied before proceeding to a phased comeback. And I'd note that the type is very small and it's hard to see. And I'm wondering if they don't really want people to see this. So I've magnified it a little bit. And so here's what it says. It says it has to have a downward trajectory of documented cases within a 14-day period. So that's pretty clear once you can read it. That before you can go to the next phase or even start opening up, you need to have a downward trajectory of documented cases within a 14-day period. Makes sense. That's sort of the incubation period of the disease. And so let's try to have an incubation period where everything's falling. So here are two countries, Italy on the left and Germany, which actually had 14 days and more than that of reduction and began to open up. Italy on May 1st, May 4th, Germany on April 20th. And we can see that they continued their downward trajectory even as they opened up, which is what we would hope to see. So what happened in the US? Well, this is Texas that opened up on May 1st. They did not have a reduction in cases before they opened up. And we saw a continued increase and then a very worrisome acceleration, which is happening today in Texas. This was Florida, which had a period of reduction, but still maintained at a high level, opened up. They did not see any further reduction, and then a sharp acceleration, which they're experiencing today. So this is New York. New York looks more like Italy and Germany. It had long periods of decline and is at an actually relatively low level for New York. And in fact, it's opening up today. And so we'll find out what's happening in New York. My guess would be that New York would more follow the Italy and Germany model. And the problem with opening up without following the White House guidelines is that it seems to encourage a rebound. And my anticipation is that those guidelines from the White House were excellent guidelines. 14 days of reduced cases before transitioning to the next level of opening up. Unfortunately, the White House has not been supporting their own recommendations. And so we're seeing states that are opening up and we're seeing a rebound. So this is all 50 case states in the US. Each one of these graphs is an individual state. The ones on the top are the ones where cases are obviously increasing. The ones in the middle where they're about the same. The ones in the bottom where they're decreasing. So there's actually two, and I would say only two places in the United States where there's actually been a sharp decline in which one could say, yes, that deserves to open up more fully. That's Guam and Hawaii. They're near zero in their cases. There's four others where the cases are decreasing, and one could reasonably argue that they could open up: New York, New Jersey, Pennsylvania, and Rhode Island. And they're having some small degrees of opening up. Here's Puerto Rico from data as of yesterday. And what we're seeing is Puerto Rico's never experienced the 14-day period of decline and is recently starting open. And it's unclear whether the new acceleration is directly related to the recent opening up or some artifact in the data, but it's worrisome. One would hope that they would not follow, Puerto Rico would not follow the example of Texas and Florida, but time will tell on that. So what is the risk of opening up too soon? In my mind, according to my value system, the problem is that the more disease there is, the more chance that an at-risk person will get the disease and die. And these are the people who cannot protect themselves. And the failure to protect the elderly in nursing homes from COVID-19, in my opinion, is one of the greatest public health failures in history. It was predictable, it was anticipated, it was avoidable, and it's ongoing today. And here's the data on nursing home mortality. as of May 31st, 10 days ago, there were 31,000. There are probably 34,000 deaths in nursing homes. Now, to put that in perspective, nursing home residents make up 0.5% of the US population, about 1.5 million people. But they make up 30% of all the deaths. So if you live in a nursing home, your risk of dying from this disease is 60 times as high as those who don't live in nursing homes. That was known from what we know about the flu and other infectious diseases. And yet, as a society, we failed to put the resources and priority in protecting that. And as we sit here today, there's a lot of work to be done in protecting these most vulnerable groups. So the other way out of it, to open up, is to have a vaccine. I spent my whole life working on vaccines, much of it with under Tony Fauci at NIH. And as a scientist, I've been involved in a lot of failed vaccine projects, as have all vaccine scientists. And so I want to come at it with a little bit more and skepticism and a little bit less, say, magical thinking. So there's dozens of serious vaccine efforts underway with billions of dollars behind it. The best minds in the world are working on it, and that's great. I would note that the same people with the same amounts of money worked on HIV vaccine for 20, 30 years and have not found an effective one. The early studies on the COVID vaccine are promising, but I would note that early vaccine studies are almost always promising. And the studies that fail, we tend not to see them. And that's because of the economic implications. For the one published study, best study on COVID-19, when the company published the data of phase 1 data, their stock price increased dramatically. And then about a couple of days later, all the senior executives sold their stock. That data was not published by the scientific community, but was as a press release from the company. So it causes skepticism that this is real. I would like to see the peer-reviewed published data in some form that doesn't have economic incentive behind it. We're heading into some phase 3 studies starting the next month or two. These are final definitive studies. And I just point out that most phase 3 studies don't lead to product licensure. Most phase 3 studies, in fact, fail. And so we have every hope that these products would work, but my experience in running phase 3 trials is that they're very difficult. And one of the things we've seen, we recently did a study, there was recently a study in China which looked at convalescent serum. So these were people who were recovered from the disease, they had antibodies in their system. It's like a serum-based vaccine because the antibodies are injected directly rather than having antibodies made. But they had to end the study early because there weren't enough sick people in China to complete the study. You have to have enough disease transmission to support enough illness to show that you can prevent that illness. And so it's very, very difficult to do phase 3 studies in places where transmission is dynamic. If the transmission is falling, so for example, in New York, it's falling, it'd be very difficult to do a vaccine study in New York. But you need to plan 6 months in advance where to do the vaccine studies, and so you can never predict where the cases are going to be. So it may be that there are technical issues to actually getting a finished study. And finally, we have about 30 licensed vaccines. All the vaccines have partial efficacy. They're all partially and consistently available, and they're all partially used. And the best example we have of this is that this year, about 80,000 people died of seasonal influenza in the US, despite having a vaccine. And so the vaccine coverage among those who got the disease was about 20%. So it's unclear that having a vaccine, even in the face of huge mortality, is something that people will actually use. So what should we expect? First is that we need to use our common sense. And these are just things we already know how to practice. Just wash our hands, cover our face when we cough, stay home when we're sick, go outside to play, don't talk to strangers, be nice to everyone. The things we learned in kindergarten. And those are a great starting point for controlling this disease. And I would think that many of these are things that we're currently practicing. one question is that we're having is all of us sort of venture out from our homes. Is it safe to go outside? And this is a study that was done in China, looking at 318 separate outbreaks. Each outbreak consisted of at least 3 different people. And they looked at the transmission dynamics of that outbreak. On the left is who was affected by the outbreak, and usually it's a family member or someone you're socially involved with. On the right-hand side is where the outbreaks took place, in home, on public transportation, at a restaurant, entertainment. And what they found from investigating 318 outbreaks was this: all of the outbreaks occurred in indoor environments. The transmission of respiratory infections, such as SARS-CoV-2, from the infected to the susceptible is an indoor phenomenon. And so these studies suggest that we're certainly safe in going outside as long as we don't have face-to-face contact. And this is from the New England Journal of Medicine last month, which they were interpreting the data about outside transmission. Here's what they said. Public health authorities define a significant exposure to COVID-19 as face-to-face contact within 6 feet with a patient with symptomatic COVID-19 that is sustained for at least a few minutes. So if you're doing, for example, contact tracing in New York, the definition of a contact in New York is within 6 minutes, talking to them face-to-face for 10 minutes. And the chance of catching COVID-19 from a passing interaction in a public space is minimal. So we shouldn't worry about if we're outside and we're not close to talking to someone. Now, the recommendation of this is to carry a mask when we're outdoors and wear it when in contact with others. But when we're not in contact, wearing a mask doesn't really have any benefit. So what about being inside? Well, this is the same data I showed you from that study that CDC did, showing that in this case, inside an acquire room can have dramatic levels of transmission. And there are a number of places where we've documented indoors transmission. And these data are the 41 largest outbreaks in the US so far. And these ones are in correctional facilities, prisons, etc. And the fact that we have people incarcerated under our care who are getting the disease is a dramatic indictment of our society. But having said that, enormous numbers of transmissions happening in prisons. These are all in food processing plants. And extremely large outbreaks. In fact, if you look down the first one in the upper left, Smithfield Foods in Sioux Falls, South Dakota, that was the largest outbreak in the state of South Dakota. And most of the cases in the entire state were associated with that food processing plant. The workers were not being properly protected. The conditions for work were not modified during the outbreak. And there was actually political pressure from the White House to keep the meat processing plants open. This was from a ship, the USS Theodore Roosevelt. And finally, number 41 on this list is actually Nursing Home Rehabilitation Center. And so we have thousands of nursing homes that follow later down this list. But basically the issue here is that any closed institution, of which prisons, jails, ships, factories are exemplars, are places where it's high risk. And so associated with outbreak, prisons, factories, ships, nursing homes, churches, family reunions, and personal services, because that's a long time contact indoors, for example, getting a haircut, have been associated with outbreaks. So the next issue is that what we would expect would be the existing public health tools will be extended. We have something in epidemiology called universal precautions, which we're supposed to use for all diseases. We're seeing those now extended into restaurants, for example. And so on the left, we see a restaurant that has built shielding, protecting the workers from the customers. The middle one is at a fast food restaurant, giving lines and the fast food workers having their masks. On the right-hand side is something we commonly see, which is now looked like permanent settings for people to maintain social distancing. So this universal precautions will perhaps finally become more universal. Secondly, the COVID-19 will probably be added to our immunity passports. These are immunity passports. The one on the left is a child passport. The one in the middle is an international travel passport. The one on the right is a military passport. We use these commonly for tracking our personal immunity, but also for admission to schools or colleges or the military or even some countries. And so it would be expected that in certain settings, COVID-19 will be added. Need not have a vaccine for that. We could have tests of immunity, or a doctor could certify, for example, that we had a disease that would put us in a position of showing that we had immunity. But I would expect that would happen, and it's not unusual. It's something we commonly do for diseases. We recently added influenza, seasonal influenza, to the immunity passport. So adding COVID-19 would not be a very big step. Another factor that we have is that we have restaurant health inspection and grading. On the left is one from New York City, where this restaurant got an A, and there's a list of things they look for, most of which are food-based disease issues. But you can see adding in COVID-specific ones, looking at distancing, table spacing, hand washing for the customers, touching, face-to-face contact. So one could then grade restaurants based upon compliance with COVID-19 disease reduction factors, and people would know and would be able to make informed decisions on whether they want to go to that restaurant. So there are COVID-specific actions. So for example, we could anticipate that businesses will compete on risk reduction for those members of the public that want risk reduction. So here was an article that appeared in Nevada about banned casinos, that they would not be able to ban smoking in the casinos because of even though COVID-19 might warrant banning smoking. But then here's another casino which is advertising being smoke-free and appealing to those people who want it. You can see that this might happen in a generic way, that people will want to get understand the level of risk reduction and act accordingly. And now we're seeing fashion statements from people selling masks. And here's an app that I use that tells noise levels in restaurants. And so I like to have a low noise level. So I open up the app on the left and it tells me green ones are low noise, orange ones are middle noise, red ones are high noise. And for me, because I like low noise, I would then choose a restaurant with low noise. One could imagine having apps that report on restaurants in terms of social distancing and give them a social distancing score. And then consumers who are more interested in social distancing or not could then choose the appropriate business. The real question is high-risk activities like concerts, baseball games, and they'll have to be modified. On the left is a picture of the 1918 flu pandemic about how baseball proceeded with masks. We'll have some version of that going forward. Although there were people in the stands at that game, it's unclear how they'll be. But on the right-hand side is a notice where normally these signs say no one under the age of 18 beyond this point. But we may see signs that no one over the age of 65 beyond this point, because they represent a risk group and the risk can't be guaranteed for those groups. I turn 65 next year, so I may be subject to this kind of issue. And finally, the issue is for us to make informed decisions. And let me go through a way that epidemiologists think about informed decision-making. So you can adopt this kind of decision-making for your decision-making. So the challenge we face is that we're all in our respective bubbles. We want to keep our bubbles safe, but we want to make rational choices about expanding our bubbles, knowing that if I get infected, I put at risk everybody in my bubble. So what's the rational decision-making? So the key question here is, if I go out and interact with people, is what is the probability that a random person on the street who is not sick is currently infected and able to transmit? Because if they're a sick person, I can kind of see they're sick maybe. But if they're not, that's a problem. So this is a study that was done among women attending births, giving birth at a hospital in New York, and they were all tested for COVID. What they found was that among those who came 13.5% were asymptomatic but positive for COVID-19. That's a huge number, and seems unrealistically high. That study was done during this period of the New York outbreak. This is the New York curve. And here's where we are today. So we can do an extrapolation and say, well, cases are down 88%. And so if we apply these adjustments to this number, we might estimate that today in New York City, about 2% of New Yorkers are currently infected and asymptomatic. Okay, we expect to get more data like this coming soon, so people will be able to make these kind of judgments without doing these kinds of estimates. So that's 1 in 50 New Yorkers. So what does that mean? So here's a curve that basically is a probability curve, which says, if we have a crowd size of any particular size, and we have 1 in 50 of these people are randomly infected, what's the probability that by any crowd size, 1 or more people in the crowd are infected? So for example, suppose I want to go into a crowd of 50 people. I want to know, well, what's the probability today in New York that anybody in that crowd is infected? Well, it turns out it's a little over 60%. So that's kind of frightening. So that's a pretty high risk and not a risk that I'm willing to take, but 60% of the people, there's a probability that 60% that at least 1 or more people in that group are infected. So we all have to think at this point and say, well, what's the level of risk that I as an individual want to take? And we might say, well, 10% is the level of risk that I want to take. And that's individualized, but let's say it's 10%. If that was the case, I could only tolerate a crowd of about 5. Well, suppose I said, well, what do I need to do to see larger crowds? And well, let's wait until transmission falls. So now it's, instead of being 1 in 50, it's 1 in 100 people. 1 in 100 people are randomly infected in New York City. I can't tell which one, but it's 1 of those 100 people. And so now what that says is, on the bottom here, is that allows me to go from 5 to 10 people on this curve. And so now, because transmission has fallen in the city at the same risk level, I can now go to larger crowds. Still, you have to ask our risk. If my risk is very, very low, suppose the risk I want to tolerate is 1%. Well, I really can't see anybody. And let's suppose we wanted to wait until it was 1 in 1,000 people were infected. Well, if I did that, then I could expand my crowd to maybe 100 at this 10% level. So that's the kind of thinking that's one can do by looking at the data, but it challenges us to ask ourselves, what is the level of risk me and my bubble can tolerate? So the Washington Post published this morning, they actually asked epidemiologists. They took 550 epidemiologists and said, okay, you guys think like this, what activities are you willing to do? And so they had 3 core questions. First question was, what might you start doing soon? And I would note that 41% of epidemiologists said they would get a haircut this summer, 39% within 3 to 12 months. So we can expect 80% of epidemiologists to get a haircut this year. That's good. Some things they were more likely to do, bring in the mail without precautions, for example. They asked what will they do later in the year? And within 3 to 12 months. So not for another 3 months would they do any of these activities, and sometime during that period they might. Visiting our parents, which seems important to a lot of us, most epidemiologists, only 41% would do within 3 to 12 months. 39% of epidemiologists wait more than a year to visit their parents. And then what they would do after a year, I noticed here, stop routinely wearing a face covering. So epidemiologists, most epidemiologists saying they're going to be wearing a face covering for more than a year. Just be truth in advertising, these are the risks that I've taken over the last several months. I went overnight on a driving distance to a house that I have in the country. I attended a small dinner party with 2 other people, friends of mine who were epidemiologists. I had dinner, but we had social distancing at the dinner party. And I traveled by an airplane back and forth to Puerto Rico. So I've done that, but I have not done any of these activities. And I do expect to be wearing a mask a year from now. So let's conclude by saying about where are we with the pandemic? So this continuum of disease control. And it starts off with pandemic, and this covers disease over time. And influenza type A is a pandemic disease, SARS-CoV-2 is a pandemic disease, and that pandemic means it's there, it's in the population. But over time, we might expect it to fall to become endemic. So we have endemic disease, HIV, Zika, tetanus, chlamydia. These are diseases which we can't control well, are present at some baseline level, periodically spike. Those are endemic diseases. The next ones are control diseases, those which we have specific control activities. Pertussis, chickenpox, we have vaccines for these. Malaria, we have bed nets and drugs. And so they might go to zero at times, but they also are controlled. And then finally, eliminated, eradicated. And two diseases, smallpox and SARS-CoV-1 have been eradicated, and polio has been eliminated. So the question is, where are we now with COVID-19? And my guess is we're here, that we've had it for a little bit, we have not yet peaked, and we're very, very much at the beginning, and we have no idea whether it's going to stop here like influenza does, go down to be endemic like HIV or Zika, or go down to be controlled maybe with the vaccine, and it seems unlikely to be eliminated. So that's sort of where we are, and I'd like to close by just quote from Winston Churchill about where may be apt for where we are. Now, this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. So thank you very much. So Glenyce, back to you.
Yes, thank you, Mark. That was fascinating and enlightening. I'm still kind of breathless just by all the information that you were able to share. Very, very valuable information, and especially when you were very specific at the beginning of the presentation saying, you know, that you have your own biases, that it was very difficult due to lack of info and everything. So greatly, greatly appreciated, because you did a wonderful, wonderful job. Let's take a couple of questions. And Kylie, I'll get to you in a minute, but first question, when you traveled by airplane, did you wear other PPE besides a mask?
So I traveled in an airplane once from Puerto Rico about 2 months ago, and there were 6 people on the airplane, and there was only one airplane in the entire terminal. So social distancing was very easy to practice. I did not wear anything extra. I did not wear gloves. I wore a mask, and I was exquisitely careful not to touch anything or not to breathe. And I would argue, and just to be aware, so I've been trained in infectious disease control, and I've been in the biological safety level labs and those sort of things. I've handled viruses before. So I have a sense of what one can do and what makes sense or not. So I feel perhaps overly so that I can control and estimate my environment in a way that my training allows me to do. And Lord knows I've been in a lot of outbreaks of bad diseases. So I would recommend, and I'm going tomorrow to Puerto Rico. I'm in New York now. I'll be traveling to Puerto Rico tomorrow. I don't know what to expect in terms of occupancy of the airplane or occupancy of the terminal. I expect it to be busier than it was. So I will wear a mask. But for me, it turns out that having the virus on your hands is not a problem. The virus doesn't come into your hands. You can have all the virus you want on your hands. Mm-hmm. What you can't have is the virus on your face. And so these viruses are transmitted through openings in your head, in your nose, your mouth, and your eyes. And so as a physician, one of the things of training we get is how not to touch our face. Oddly, they have a line where your chest is. Never raise your hands above your chest when you're dealing with a patient or in an operating room, for example. So it's very difficult to do not to touch your face. It's something that can be achieved with practice, but it's something that I know about not to do that. And I feel that's a skill that will help me to get through an airline flight.
We might have to do a webinar to give us some tricks for that. That's great. Your recommendation to open or not preschools, and I'll expand it to schools, I guess.
So, it's actually really interesting that there's a number of models out there about how to open schools safely, recognizing that we're not going to open them the same way. And so I would say, what are the things that we've applied to other institutions that we've opened up? We have social distancing, we have physical barriers, we have hand washing, we have limited access. One idea is to have kids 1 week on and 1 week off. Another idea is to have one half day and one half day. The problem is that, for example, in New York City, a lot of the kids who go to school ride the subway, for example. And so there's a whole ecosystem around kids going to school and the other people that kid puts to risk. So if the kid lives with his sick grandparents, I would put that in a different category than a child who lives with young parents by themselves. So I would think that it's possible to open up schools, but I would apply the same lessons that we've learned from the other institutions that we've safely opened up and have no expectations they would open up as we've seen them in the past. And as a parent, I would demand that of the school, and I would want to have some assurance that they're doing that and that the school is conscientious about that. And I think that the school should have that conversation with the parents and say, what are the risk tolerance of the parents about this? But I think that this is a question of being clever, I think, rather than being strict in terms of not opening up.
Okay. Likelihood of a second wave. And I'll echo that as well, because on the data, you showed a lot of these states that are kind of the coastal states, but not the states in the middle. So could there be like a second wave?
So we're already seeing a second wave in some places. So for example, Florida is already seeing a second wave. Now, if by a wave we mean that it went away and came back, like a sine curve where it was reached a low point and then reached two separate high points, we haven't seen any areas where it went down to near zero, stayed at near zero, and came back. What we've seen is places that reached a high peak, had a modest decline, maybe 50%, and then went back heading up towards their peak. So my expectation is that the disease will be with us always, and that wherever there are susceptibles and high contact rates, there will be transmission. And I anticipate that in the fall, when some places try to have schools, theaters, basketball games, and people's memories are short, and the weather is more conducive to the virus, that we will have a second wave. In terms of a response to that, I don't think the society is going to tolerate shutting down again. Yeah. For me, what I think this means is that we need to put protections in place for the most vulnerable. If as a society we can protect nursing homes, prisons, meatpacking plants, Navy ships, choirs, if we can do that, then maybe it's okay to allow more transmission because the risk of mortality will be much lower in the society. We've not yet done that as a society. We still have those at high risk are still at high risk, and nursing homes are getting infected every day. So I would say, as a society, we should demand of the society that we protect the high risk person as the gateway to us allowing more risky behavior by the other people.
Definitely. Yes. So Omaya, this is a great question, and I had this question as well. What is your opinion on the quality of the data in Puerto Rico and what it can tell us, if anything? And I kind of want to let you answer that and expand also into what have we learned globally from this pandemic in terms of collecting data? but you can answer the first one first.
So when the Puerto Rican outbreak started, I was consuming the data from Puerto Rico continuously, following every case and every death. And I learned over time that the data doesn't merit that close of attention because the data has flaws in it that does not allow one to draw conclusions that are very tightly argued from the quality of the data. And so occasionally glancing at the data, seeing where the larger trends are going, is probably the best one can do. I think there have been some unique problems in Puerto Rico in the way the data are reported and handled and confused and delayed and that sort of thing. I don't think it interferes with drawing a general conclusion, which is that A, there's community transmission in Puerto Rico. B, there are some deaths, but not as many as you might have expected, so something is happening good with the deaths. 3, that the hospitals are not being overwhelmed, that there are plenty of ICU beds and plenty of respirators, and so the idea of flattening the curve was to preserve hospital capacity. Puerto Rico has successfully done that. So as I look at the Puerto Rico data, the thing that is most important to me is respirator and ICU capacity. Mm-hmm. And as long as those stay available, I'm not really certain what to draw from the idea that there are daily fluctuations in the case data. As long as there are not a lot of hospital admissions or dramatic increases in hospital admissions, it may be that the virus is circulating among low-risk people and not causing severe disease, and that may not be a public health problem. That may be tolerable for what we're doing. So it may be that Puerto Rico has made advances in protecting the at-risk people. It may not have those institutions and the very few nursing homes in Puerto Rico, for example, that would cause rapid, widespread transmission among the high-risk groups. You asked a question about global data. What was the question?
Yes, and I wanted to ask you to stop sharing so people can see you on a bigger video. But my question was, yes, beautiful. Thank you.
Is that okay?
No, try to click exit again or just stop sharing at the bottom of the screen.
Stop, I don't know what to do here. Oh, so stop share, I see.
Yeah, there you go. Beautiful. Now you're bigger and people can see you. Awesome. No, thank you.
All right. Okay.
So my question was at a global perspective, and with your global perspective, what have we learned of data gathering? You know, since you showed all these graphs from different places and countries, have we learned anything about how to gather data so we can actually compare things?
So there was a lot of confusion at the beginning, and testing quality wasn't available or high quality. I think the single most important thing that I've learned is A, the public health system works, that the system is able to respond and there's enough experience in the system to have rapid understanding of what to do. There wasn't a lot of confusion about here's what we need to do and here's how fast we need to do it. A universal recommendation from the public health community. The thing that's surprising me is the political nature of the data and how, particularly from leadership in the United States, how there's interpreting, collecting, defining the data has become politicized in a way that it hasn't been in other countries. And I think the connection of the citizens to the data is stronger in other countries. So if I'm in Sweden, I have my data and I can trust my data. I know it's unbiased data and I know that it's been collected with some degree of integrity. I don't know if we can say that in the US at this point. Right. And so it may be enough for us to draw trends, but the kind of precision we want in the US is just, I have to say that I'm uncertain, which makes me sad. I thought we were the world leader in quality of data, but I have to say that I don't think that anybody at this point can give as much credibility to the data that we're collecting on this as we're seeing even for other diseases in the US.
Good. So we have a couple more questions just before we go. Is there more than one strain of novel coronavirus?
Is there what?
Is there more than one strain of novel coronavirus?
Yeah, so I think they mean novel coronavirus.
Novel, okay, or that was me in the reading.
Yeah. So for this, the question is, it sort of gets on the question of mutations of the virus and what's the meaning of those mutations. And for this, I have had a lot of conversation with virologists about what it means. This is a single-stranded RNA positive strand virus that mutates constantly. The question we have is not does it mutate, which it does constantly, but are those mutations meaningful? Most mutations are lethal, in fact, to the organism that has it. And what we've seen for this virus are no clinically meaningful mutations, period. And so nothing has happened that we've been able to prove that it's more lethal or it spreads faster or it changes its receptor binding or any of those factors that one might determine a meaningful one. It might happen in the future, and we would expect that viruses mutate. They generally mutate to becoming less lethal because for a virus to kill its host is a dead-end strategy for a survival. Right. So the last thing an organism wants to do is kill its host. So they generally become less lethal. But as we stand today, we haven't seen any mutations that have any clinically important meaning to them.
Good. Is there any data on COVID infection on patients with chronic disease, for example, cancer?
Yes. So there was a study that was done that looked at hospitalizations in New York and asked what, if any, were the underlying risk factors among those who had severe disease and died. Now, remember, these are mostly elderly people as well. And so it turns out that something like 80 to 90% of those who have severe disease or death have underlying disease. And the underlying disease are generally diseases of the lungs or circulatory system. So let's think lungs, heart, hypertension, and there are certain diseases, circulatory diseases, that affect the kidney, for example. And one of the reasons that this is happening is because the virus SARS-2 now, and then the fact SARS-1 also, has as its receptor a cell which lines blood vessels. And so often respiratory viruses affect respiratory tissue, and it then damages those tissue. This virus actually infects the epithelial lining of blood cells. And so the lungs are rich in blood cells, the kidneys are rich in blood cells. And what we're seeing is specific diseases of the circulatory system, like strokes or deep vein thrombosis or clotting factors. This disease that we're seeing in children, which is Kawasaki's-like disease, is a disease of inflammation of blood vessels. So a lot is known about this, but certainly people have lung disease, circulatory system diseases, hypertension, because hypertension has some connection to these receptors that the virus uses in the blood vessels is somehow related to the hypertension. And then certainly, of course, anybody who's immunocompromised for whatever reason, cancer treatment, et cetera. But those risk factors in terms of underlying disease are pretty well characterized at this point.
Beautiful. So yeah, two more questions. If COVID-19 is actually a vascular disease, does this change the trajectory for effect treatment? Examples, statins of other drugs for vascular? Statins or strains, I guess?
Yeah.
Another drug for vascular?
Yeah, so this is an interesting question from a person who obviously has some knowledge of this. So as I was saying, the receptor is one that's on blood vessels. And it's also a receptor that we use for drug treatment. Certain kinds of drugs are used to lower blood pressure, block these receptors. And these receptors are everywhere in your body where there's a vessel, and there are vessels connected to almost every cell in your body through capillaries. So it certainly means that what we're seeing are diseases of circulatory systems. And so one of the things that's most interesting is that the virus goes away fairly quickly, not universally, but fairly quickly, say within a week or so of onset of symptoms. But we're seeing people being admitted with severe sickness a week or so after the virus has gone away. So what they're seeing is a response of their body and their immune system and other organ systems to a response after the virus has gone away, sort of an immune system on overdrive, which is trying to essentially inflame its own tissues to make the disease go away, even though the virus is not there anymore. This has enormous consequences for how we treat the disease. So if we're not treating the virus anymore, then antivirals like remdesivir, this drug, is not really effective. But it means that we have to focus on basically treating the person's symptoms and not treating the virus going forward. And that's been a very difficult, very challenging, but I have to say that the clinicians have been real heroes in figuring out these various forms of these new fancy immune system suppressants to use to control this factor. So yes, it's a disease of blood vessels. It uses some of the same receptors as drugs use, but we're well aware of it. We need to understand it, and the in-hospital survival rate has been improving because of our experience in being able to use these immunomodulators in treating it.
Wonderful. So yes, we will send the presentation and the recording of this webinar and Mark's contact information from the email to everybody that registered. And Mark, we have another question, which I think it's more for kind of thoughts. What are your thoughts on the impact of COVID and Black Lives Matter protests? And you did mention that it affects Blacks more.
Yeah.
Even though they are outside, though, which is a good thing.
So let me give you two. One is that about a personal bias I have, is that when I heard that the president wanted to have a political rally of 10 or 20,000 people in North Carolina, I thought that's ridiculous. That should be stopped, and we should not have a political rally like that. But then when I saw Black Lives Matter protests, I thought that's a good thing. So we should allow that. And so just like that, part of my opinion on this is not as a scientist, it's as a person, understanding that some rallies are okay and some rallies are bad.
Right.
But I think the analysis of disease spreading should be equal for both of those, regardless of my political bias. And the analysis is that these multiply the virus. If there are people who are breathing on each other, the probability of there being infected people in those crowds of hundreds or thousands is really enormously high. So if I were going to a rally, I would protect myself. I would wear a mask. I would try to social distance if possible. I would not touch my face, and I would wash my hands. So I think that everybody needs to take their own risk assessment and practice that. And for some of us, making a political statement is extremely important. And so we're willing to take additional risks during those times. Now, it affects our bubble also. So going home to our sick parents might be something we need to take into consideration as well. But it does expose my personal bias about how I assess risk, but to be unbiased about it, it certainly multiplies the disease.
Definitely, I'm with you. Thank you so much, Mark. Thank you for everybody that attended and for all these wonderful questions. The recording will be sent out along with the presentation. You already have this link in your chat question. Mark, so thankful. Please be safe tomorrow on your travel back home. We'll be waiting you here with open arms.
I'm looking forward to it.
Awesome.
I might even go to the beach. We'll see.
Yes, beach is a great place. It's open and you keep your distance and it's nice and hot, so good environment. Well, thank you so much. Thank you, Mark, and thank you, everybody. Have a great afternoon. See you during the week. Oh, we have 2 webinars coming up, Tuesday and Thursday on education. You should have that information, but we'll be sharing that again, just a small reminder. Thank you so much. Thank you, Mark. Be safe.
Thank you.